Throughout my interviews, I have heard a great deal about healthcare policies affecting elders and family caregivers. Learning about this, I wanted to interview a healthcare advocate who really understands the challenges within the healthcare system and within Medicare and Medicaid. And there was no one better that I can think of than Mark Hannay. In the following interview, Mark discusses the Medicare policies that affect the health of elders, the type of services that are available to help caregivers better understand these policies within the Medicare and Medicaid system, and what you can do to bring about reform. Stay tuned. Okay, welcome, Mark. It's such a pleasure to have you here. I'm excited to hear about your background and your story and your experience as you share with us about your access to healthcare. So please, without further ado, tell us about yourself.
Okay, well, I have been director of a small nonprofit healthcare advocacy coalition for over 30 years now. It's called Metro New York Healthcare for All. It was formed in the early 1990s as a way to respond to the healthcare reform initiative of the then new Clinton administration coming in that wanted to do major healthcare reform. Unfortunately, that didn't happen at the time. We had to sort of wait till 12 years later when the Obama administration came in. So we eventually did get around to doing it, but that was kind of my first wading into the waters on things. I was a staff person working on health policy issues related to New York State government, particularly health insurance issues. And I was working at Gay Men's Health Crisis, GMHC, at the time, on a part-time basis, sort of handling those issues for them. And I was tasked by the agency to participate in this new ad hoc coalition that had come together, bringing labor unions and community groups together as part of sort of a national effort where local coalitions were being set up to try to engage in and influence the legislative process in Congress to try to craft a major healthcare reform bill. And so that's kind of how I got into all this kind of work. I didn't know too much about healthcare when I first started into it. I was just an AIDS activist at the time, working with some other folks on health insurance issues for people living with HIV/AIDS at the time, and we sort of taught ourselves a lot of stuff. We were working with a few people who had worked in the industry and knew about it and mentored us and so forth, and undertook a successful campaign here in New York to pass legislation to reform our health insurance laws so that people were protected against discrimination based on pre-existing health conditions. It was considered a landmark law at the time and became the basis of one of the core aspects of what later did get enacted under the Obama administration, the Affordable Care Act. And so we got that law through, and it was through that I got to know and work with people at GMHC, and then they brought me on board to do some of that work for them when the Clinton administration first came in.
Wow, fantastic. Thank you so much for sharing about your such a rich background and experience. And I know that you have won awards and are a very well-seasoned healthcare advocate. So it's really...
I've learned a lot of it by the seat of my pants and gone along with people mentoring me and so forth. So that's kind of been my history. I never went to college to study any of this stuff. I think I had a bit of personal experience growing up. My mother was type 1 diabetic from when she was an early teenager, and so had a lot of experience back then. The diabetes treatments and so forth weren't anything like they are today.
Wow.
So she was in and out of the hospital a lot, and so I had a real kind of familiarity with that sort of experience and encountering the healthcare system. So there was not a lot of mystery to me, as it were.
Got it. So I know that you have a lot of breadth and depth to the experience of healthcare advocacy. And as we think about the growing baby boomers and aging population, and,
which I am one.
Yeah. Congratulations.
Thank you.
Let's talk about that. Like, what are the sort of the hot topics now that's affecting elders in healthcare?
Well, I think the increasing complexity of the healthcare system, the consolidated industries, these big behemoths that have been formed over the last decade or decade and a half, the hospital networks, the consolidation of the insurance industry, the partial privatization, if you will, of Medicare, and the I don't know if intrusion is quite the word, but the emergence, let me put it that way. Intrusion and emergence, because it's really been both. The sort of managed care model into both Medicare and Medicaid, the two primary public insurance programs that older people rely on. And then sort of overlay that with changes in the healthcare delivery system. So there's sort of two sides of a coin. One is the covered side of things. The other is how do you access and get the care you need and use the system to get the services and so forth. So I think those are two really complex things, and they've gotten more complex as the years go along, and particularly as now I've started to enter those systems a bit more as I've gotten older. I mean, I sort of know and understand the systems a bit, and it's perplexing to me. I can't imagine how a normal everyday person understands and navigates this. It must be a total challenge to them.
It reminds me of the rollout of the first line of COVID vaccination for the aging population or for, for elders. And it was an absolute public health disaster because they have no access, and many of them don't even know how to navigate online systems. So they couldn't even make an appointment to get the vaccination. Remember that?
Right. Yeah.
I'm getting the sense that this is sort of a similar experience as well, because just to go in and just to apply for it can be a daunting task for someone. And also, too, we know that in poorer communities or low income communities where the internet system, the Wi-Fi is not that reliable, right?
Yeah. I mean, challenge for the healthcare, there's two challenges, I think, particularly in the U.S. healthcare system. One is, and both of these challenges make it such that the patient themselves is a second or third tier concern. The first concern is about the money. It's like who's paying for what, etc. How's all that working? How does it flow? And making sure that the people who've got their fingers in the pie get what they're seeking out of that pie. And they're always trying to grab bigger and bigger percentages of that pie.
Okay.
And so that's one challenge. And then the second challenge is just the needs of these complex systems for them to function. So the way the system operates is built around what's the needs of the system rather than the needs of the patients. We don't construct the system around how do we meet the patient needs. It's around what does the system need, and then how do we somehow squeeze the patient into that. And the system to the patient, I think, often appears and literally is in many cases very Rube Goldberg-esque and Kafka-esque. And so we're very much putting the cart before the horse, in my opinion.
Thank you for mentioning that, because that seems to be a consistent experience with some of the folks I've interviewed in the past, and they talk about this. And I wonder what do you think we can do, or say elders, what sort of the best sort of means for them to gain access to healthcare? Like, what sort of advice can you give us?
Oh my God.
No pressure.
Yeah, right, exactly. Well, we need to be talking to policymakers about how the whole system really, in line of what I was just saying, needs to be revamped in a way that just makes things simple, simple, simple. If there's one word I could scream out to the universe or the system operators and so forth, is like, let's simplify that and center it on the patient and go from there. And that's not how our system has come into being and been built up. So that's we can't obviously sweep the whole thing away and start from scratch.
Right.
We kind of have to start with what we've got in hand and sort of step by step move in different ways in different directions and make changes and very much take the long view on it. So I think that's just some general advice that I would say. I'm not a particular individual patient advocate. I've done some of that.
Right.
Mine is more looking at policy and systems. That's where my work has focused a bit. But as the phrase that's very much come into vogue in the last decade or so has been centering things around who are the directly affected people and starting from there, listening to their voices, and bringing them into the conversation so that they're part of crafting the change, the solution, and so forth. There's a phrase that we've often used, really going back to my early days when I got into this in the AIDS activist movement, of like, if we construct a healthcare system that meets the needs of the people who rely on it and use it the most, particularly people with chronic, serious, life-threatening illnesses, people with disabilities, and so forth, if we craft it with those folks in mind, then it will de facto work for everybody else.
Yes, I agree with you.
But that's not how it works. It's,
Yeah, I'm totally agree with you. And I think that it works sort of a little bit backwards.
Absolutely.
On that, sort of speaking about creating that access and understanding the users, the consumers, and working with them and sort of building that up. One of the things that sort of comes to mind is like, it's such a challenge for even the terminologies that they use in Medicare, for example, and supplemental insurance or the advantage plans and sort of breaking all that down and explain. I mean, from a policy level, do they have agencies and groups that are funded to help?
Oh, yes.
Okay.
Yeah. Here in New York, we're very fortunate. There's a network of nonprofits across the state called Community Health Advocates. It was created with seed money offered to states under the Affordable Care Act when it first came into being. And since then, the state government, the advocates working with state officials have now created a permanent funding stream for these agencies to offer these services. So that's one place that people can go for, no matter what kind of health insurance you've got, or whatever age is. This Community Health Advocates program, it's communityhealthadvocates.org on the internet. You can find the local agency in your community. They have a toll-free hotline. So that's very much a resource that I would direct people to. Another one, particularly for lower-income people, been around for years and years and years, legal aid organizations here in New York City, the Legal Aid Society, and so forth. Those kinds of organizations across the state can really help people with legal services to sort out a whole variety of things, including healthcare benefits.
Oh, really? Oh, wow. That's fantastic.
Right. And then we also have a hometown organization that has started out here locally in New York and then has since gone national in scope, the Medicare Right Center, which is really a go-to source, anything related to Medicare. I talk to them because they know all the ins and outs and tricks and so forth. And they also have a hotline. They have a great website called Medicare Interactive that people can use to answer all kinds of questions and get information and get help and assistance. So those are sort of three resources that I would recommend for people.
Wow, that's fantastic. Now, I do know that there is, I guess, some patients maybe qualify for Medicare and Medicaid. How does that work?
Well, you qualify for Medicare because of either age or disability. Mm-hmm. And then if you're low income, then you would also qualify for both programs. So the theory is that Medicare is your primary coverage program, and then Medicaid wraps around it and sort of fills in the gaps, either in terms of missing benefits that Medicare doesn't fully cover or your out-of-pocket costs and so forth. And the good news is that slowly but surely New York has been still strengthening its Medicaid program that is available to wrap around Medicare for lower income people, raising the income eligibility levels and making it easier for people to get on that program and to use that program, making those programs work better together, because Medicaid is a joint state-federal program, and each state is kind of responsible for the nuts and bolts operation of it. But Medicare is a strictly federal program, and so kind of fitting those two things together is not always easy. But New York has taken steps over the years to do that. Now, that said, it's far from a perfect integration yet, but we've been taking steps in the right direction, and these agencies that I just mentioned can help people sort all that out, because it can be a bit of a challenge.
So, if you don't mind me asking, so what kind of healthcare policy issue are you working on now? Does it affect elder care?
Oh, yeah. I mean, we have a number of different things that we focus on, but one of them is we help to lead a statewide coalition of healthcare advocates and sort of general political activists that focus on healthcare issues, among other things. It's called Healthcare for America Now, which is a national umbrella coalition that was formed in the late 2000s when the Obama Healthcare Reform Initiative emerged, and it brought together a whole lot of different constituencies to make sure that, we got the best law through that we could and kept bad ideas off the table and so forth. And the way that it did its organizing work was out in the states. And so they helped to create sort of multi-constituency coalitions out in the states.
Okay.
It was really kind of a new political organizing model at the time, because rather than either parachuting in folks from the outside or creating new organizations out of whole cloth in states, what they did was they tasked people with bringing together existing organizations and groups to build these sort of networks. And each network in each given state was like, your job is to focus on your 2 U.S. senators and the Congress members for your state. Don't worry about anybody else anywhere else, because your job is to. So our job in the case of New York was to focus on the New York delegation and the New York senators. And that's what we did. And it's called the New York State Network for Healthcare for America Now. And we convene these folks. We meet more or less weekly, focusing on federal healthcare issues, whatever's coming up in Congress or coming out of the White House or whatever that we need to focus on, and also try to inject some of our issues onto their agendas to say to them, what's really important. So, we got what's now known as the Affordable Care Act legislation through. We worked on getting it implemented here in New York. We then had to go through a process of defending it when the Trump administration came in. You may recall there was a whole effort to sort of, quote unquote, repeal and replace the ACA. They were all sort of gung-ho about repealing, but they could never figure out what was going to replace it. So that sort of effort failed, but we did have to mobilize. And all across the country, similar efforts happened in states. And we helped lead the effort here in New York. We successfully did that. So, and then the next thing that kind of really came along were bills around the pandemic response. And there were, I think, roughly, when all was said and done, probably about half a dozen pandemic-specific bills that got through Congress over about a 2-year period. The last one being the American Recovery Act, Rescue Plan Act, the American Rescue Plan Act, when Biden first came in. And there was some stuff there that we could build on. And then the next thing out of the gate was the Build Back Better project that the Biden administration was pushing, that was supposed to be, it was designed to be a sort of post-pandemic response. What are some things that we know now, given the experience of living through the pandemic, people need on a whole variety of fronts, including healthcare. And so we got some legislation through then, and the outcome of that process was the piece of legislation known as the Inflation Reduction Act, which primarily focused on healthcare, climate change, and a bit of tax reform. And the healthcare piece of that was mostly about prescription drugs and Medicare.
Oh, okay.
And although the Medicare drug benefit had been created back in the early 2000s, about 20 years prior, there was a specific piece of that legislation that specifically forbid the Medicare program from negotiating directly with drug manufacturers to moderate drug prices and to negotiate drug prices that were fair and reasonable.
Mm-hmm.
And what happened, one of the major pieces of the Inflation Reduction Act was creating a whole new system for Medicare to directly negotiate with drug manufacturers over prices, but also did some other things to moderate drug prices for people on Medicare. At the time, the push was to try to get this kind of across the board for all kinds of health insurance, not just Medicare. But the way it all played out in the end, it was just about Medicare, and the provisions of that law that around Medicare drug prices have been sort of rolling out since then, year by year, and the whole system will come to fruition starting in 2026.
Wow.
So there are things like drug companies can't raise their prices in any given year faster than the general rate of inflation. People on Medicare now get free vaccines. They're not paying anything out of pocket. It capped their annual monthly out-of-pocket costs for people needing insulin at $35 a month. There's now new annual out-of-pocket costs for drugs for people on Medicare that this year are $3,000, and then you don't pay anything more out of pocket in terms of deductibles or copays. It got rid of the catastrophic benefit that had existed in the Medicare prescription drug program, where it used to be once you got up to a certain level, you were still paying 5% of whatever the cost is. And for people who had really serious needs for expensive drugs, that was a huge problem. So it got rid of that completely. Those are capped now. So there's a bunch of things. I'm just riffing off the top of my head. I don't have my cheat sheet in front of me. But so there was a bunch of things that happened there. And now I think the next big thing facing us as a nation is there's been a lot of talk about how do we protect the financing for Medicare over the long haul. There was a trust fund set up 40 years ago during the Reagan administration that's projected to start running short of money and somewhere in the next decade. So what are we going to do about that? There's been talk of setting up a special commission that would meet behind closed doors, and then there would be a proposal emerging from that would be fast-tracked through Congress. There's a lot of problems around that sort of an approach. But at any rate, we need to think about how do we simplify and streamline Medicare? How do we add missing benefits to it, such as dental, vision, and hearing benefits? There's been some talk about long-term care, which right now happens mainly under the Medicaid program as opposed to the Medicare program. Should we be thinking more about strengthening the modest long-term care benefit that does exist under Medicare? And so there's a number of questions about all this sort of stuff. How do we cap the annual out-of-pocket costs for people on Medicare for their Parts A and B? Part A being hospitalization, Part B being major medical, doctors, labs, and so forth. Because right now it's an open-ended situation. If you get really sick or whatever and require a lot of hospitalizations or a lot of doctor's visits, labs, tests, and so forth, you're paying 20% under traditional Medicare of every single one of those bills. And
wow.
So we definitely need to cap that for people. At a certain point, you don't pay anymore.
Right.
They've started to do it now, as I was saying, for the Medicare Part D drug benefit. So how do we do that for the rest of Medicare? So there's a number of things that we need to think about. And I know that's probably going to be on the table under the next Congress, whatever the balance of power may be there, under whoever gets elected president in this fall's election. So one of the messages that we're trying to do as advocates is sort of say, the future of Medicare, healthcare, but particularly Medicare, is on the ballot this fall, and helping voters understand what's at stake and what the candidates' positions are, what the options are, so that they can be informed voters when they go to vote, and that it's really important that you get out and vote this year, that you don't stay home, because all of this stuff is on the table.
Yeah, wow.